Thank you for listening to Depictions Media Radio. Africa, during the whole pandemic since has gone on, has had a number of issues, and in our next segment, the WHO Africa doctors are going to be discussing those issues and maybe some solutions to how they all can be solved with a poignant message to the world and the people who live on that continent.
Good morning, Dr. Moeti. Good morning, everybody. I'm Elizabeth Kwaovi, and I wish to welcome you to the WHO Africa Media Briefing, which is taking place in collaboration with the Apple Group. First, some housekeeping messages. You can choose the language of your choice by going to the globe on the bottom right and selecting your language. And in French, bonjour, je suis Elizabeth Kwaovi. Vous pouvez choisir la langue de votre choix en cliquant sur le globe terrestre qui se trouve en bas à droite de votre écran. Joining us today from Brazzaville, Congo is Dr. Matshidiso Moeti, WHO Regional Director for Africa. And Dr. Moeti, I will now let you introduce the other panelists as well as provide us an update on COVID-19 in the region. You have the floor.
Thank you. Thank you very much, Elizabeth. Good morning and good afternoon. Bonjour, bon dia, to everyone joining this press conference, where we'll be looking at COVID-19 treatment capacities in African countries. For this conversation, I'm very pleased to welcome Professor Dai Ka, who is an infectious and tropical disease expert and member of the treatment pillar of the COVID-19 task force in Senegal. I'm also happy to welcome Dr. Norbert Njeka, the Director of Drug-Resistant TB and HIV at the Department of Health in South Africa and team leader for COVID-19 case management. Our panelists will tell us about how their countries are ramping up treatment capacities as part of readiness for a resurgence. On the African continent, there have now been more than 4.8 million COVID-19 cases, and 131,000 people, sadly, have died. In the past week, 74,000 new cases were reported, an increase of 9% over the previous week. We're seeing rising cases in South Africa and in countries like Uganda and Namibia, and cases have increased abruptly in 8 countries, including Sierra Leone, Guinea-Bissau, and Nigeria in the past 7 days. We've seen how COVID-19 can quickly overwhelm health systems that are not equipped to manage a surge in cases, so critical care capacities remain vitally important. Since the start of the pandemic, supplies worth $123 million have been shipped to African countries through the UN Supply Portal, which is coordinated by WHO. These include around 3,700 oxygen concentrators, 1,300 patient monitors, and 700 ventilators, with 300 more in the pipeline. These investments have gone a long way in building capacities to manage moderate and severe COVID-19 cases. However, many African hospitals and clinics are still far from ready for a surge in critically ill COVID-19 patients. Looking at countries in Europe and the Americas, those with more than 25 intensive care beds per 100,000 population were able to meet the increased demands when cases surged. However, among 23 African countries responding to a WHO survey in May this year, only 5 have more than 5 ICU beds per 100,000 people, and most countries, unfortunately, have less than 1 ICU bed per 100,000. This reflects decades long of underinvestment in health systems, among many other competing priorities. These capacities are desperately needed now and need to be ready to face future threats. An assessment by PATH, the Global Health Organization, of oxygen requirements in 24 African countries during the January peak indicated that depending on each country's epidemiological situation, they required between 1,000 and 700,000 cubic meters of oxygen a day. None of the countries assessed were able to meet their needs. Attention is also needed on the quality of care being provided. And a recent WHO analysis of COVID-19 clinical management protocols in African countries revealed that just over half recommended antibiotics such as azithromycin for mild cases, and 80% recommend antibiotics for moderate cases. However, this treatment may be largely ineffective, as we know that antibiotics don't work against viruses and should only be used if patients develop a secondary bacterial infection. To prepare for a resurgence, as WHO, we are mobilizing case management experts, as we did also in response to previous waves in countries like the Comoros, Guinea-Bissau, Sao Tome and Principe, and others. We are pre-positioning $2 million worth of essential commodities, including 1,000 oxygen concentrators that can be deployed quickly when needed. And partners in the USA, Portugal, and other countries have signaled their readiness to deploy emergency medical teams in the event that local systems need to be reinforced. Investing in critical care capacities in African countries now will pay dividends for the COVID-19 response, along with strengthening health systems to manage major killers like childhood pneumonia, as well as post-cardiac arrest, pre- and post-operative care, and traumatic injuries, among others. This will result in health development gains for generations to come. Turning then to the update on the vaccine rollout, 31 million doses have been administered in African countries. 7 million Africans have received 2 doses. In sub-Saharan Africa, we're at an average of 1 dose per 100 people, compared to a global average of 23 and 62 per 100 in high-income countries. The gap between vaccinations globally and on the African continent is increasing despite the best efforts of African countries because of vaccine inequity. This is a great concern for us, and it was strongly expressed by many ministers of health during the just past World Health Assembly, which is the global meeting of all the world's ministers of health. They emphasized the need for immediate sharing of doses and for longer-term expansion and diversification of production capacities. Nearly 20 African countries have now used more than 2/3 of the doses they've received, and many of these countries are ready, willing, and able to rapidly roll out more. The threat of a third wave in Africa is real and rising. Vaccines are key to staving off a new surge and keeping the most vulnerable Africans out of critical care. Vaccines are truly a gift that will keep on giving. As we are expecting a surge, it's important to strengthen health systems now to save lives. And public health measures remain important to prevent infections that can later become hospitalizations. So I thank you again for having joined us today, and I very much look forward to our discussion.
Thank you very much, Dr. Moeti. Let me turn to Professeur Bayeka. Professeur Bayeka, vous êtes parmi nous. Est-ce que vous pouvez nous parler de la façon dont le Sénégal a réussi à gérer...
Bonjour, vous m'entendez?
Oui, je vous entends très bien. Est-ce que vous m'entendez aussi?
Oui, je vous entends. Je suis bien avec vous.
D'accord. Professeur Bayeka, est-ce que vous pouvez nous parler de la façon dont le Sénégal a réussi à gérer le traitement des cas de COVID-19?
Oui, bien sûr. En tout cas, bonjour à tout le monde. Et c'est un réel plaisir donc, pour moi de participer à cette conférence de presse que je trouve très importante. Alors, donc, moi, je suis médecin infectiologue. Je suis membre du pilier traitement donc, pour ce qui est de l'AMS qui a été mis en place pour la COVID-19 au niveau du Sénégal. Et donc, comme nous l'avons tous constaté, donc cette première vague, elle était marquée par cette deuxième vague, autant pour moi, était marquée par une augmentation du nombre de cas au niveau, à l'instar de tous les pays, au niveau national, donc au Sénégal, au niveau de toutes les régions. Nous avons assisté à une augmentation du nombre de cas. Et cette augmentation du nombre de cas également a coïncidé, donc se faisait parallèlement avec l'augmentation du nombre de cas graves. Donc, ce qui a fait qu'au moment de cette deuxième vague, nous étions confrontés à une tension, donc surtout concernant les lits de réanimation. Vous savez que la prise en charge des patients graves nécessite vraiment des lits de réanimation bien équipés. Donc, on a eu beaucoup de soucis par moment, mais également, on a également été confronté à un défaut de production d'oxygène, donc pour certains patients. Si l'on sait que dans le cadre de la COVID-19, donc pour les personnes qui ont des formes sévères avec un syndrome de détresse respiratoire, ils ont besoin de beaucoup de quantité d'oxygène. Donc, par moment, on était confronté à une production, à un défaut de production. Mais il faut signaler qu'au niveau du Sénégal, donc même pendant la première vague, donc vers la fin de la première vague, donc pour décongestionner donc les hôpitaux, les CTE, les centres de traitement des épidémies, donc on avait opté pour la prise en charge à domicile, donc des cas, surtout les cas simples, donc qui étaient âgés de moins de 60 ans, mais également qui n'avaient pas de comorbidité. Et donc, c'est pourquoi, avec cette augmentation du décès lors de cette deuxième vague, donc nous avions constaté que presque la plupart des décès survenaient chez des patients qui avaient des comorbidités, notamment l'hypertension artérielle, donc le diabète, donc les maladies cardiovasculaires, l'obésité et également les maladies pulmonaires chroniques. Mais également, survenaient le plus souvent des sujets qui sont âgés de plus de 60 ans. Donc, ainsi, donc, pour améliorer la prise en charge des patients, donc, afin de réduire la mortalité, car nous avons constaté que lors de cette deuxième vague, il y avait une augmentation de la mortalité. Donc, plusieurs mesures ont été prises. Donc, ces mesures concernaient essentiellement donc, l'augmentation de la capacité litière, donc surtout des lits de réanimation. D'ailleurs, même, il a été mis en place un hub de réanimation, donc un centre de réanimation sur lequel je reviendrai. Mais également du fait de la fréquence des comorbidités chez ces patients qui décédaient, on avait impliqué beaucoup de spécialistes, notamment les réanimateurs, les pneumologues, les diabétologues, les cardiologues, les néphrologues, les gériatres, les gynéco-obstétriciens et les pédiatres. Et également, c'est à l'issue de plusieurs réunions et d'ateliers avec ces différents spécialistes que nous avons mis en place des algorithmes décisionnels pour la prise en charge, mais également des protocoles. Donc, beaucoup de choses ont été revues, surtout avec l'implication des autres secteurs. Donc, il fallait vraiment avoir une prise en charge multidisciplinaire. Et donc, également, nous avons procédé à la supervision des centres de traitement au niveau de la capitale, mais également au niveau des régions, donc pour voir quels étaient les points forts de ces CTE, mais également quels étaient les points à améliorer par rapport à ces différents CTE. Donc, c'est ce qui nous a permis, ainsi, donc, après, à l'issue de plusieurs ateliers donc, de formation, nous avons mis en place donc, ces algorithmes et tous les acteurs impliqués dans la prise en charge, aussi bien la prise en charge à domicile qui était assurée par les districts que la prise en charge au niveau des CT ont été formés sur les algorithmes en présentiel, mais également en ligne. Également, des supervisions ont également été faites. Et donc, comme je l'ai dit tout à l'heure, donc devant la multiplication des cas graves, on avait mis en place un hub de réanimation, donc au niveau d'un secteur donc extra-hospitalier. Donc, on avait équipé ce secteur de lits de réanimation, mais qui n'a pas pu être utilisé, car au moment où ce secteur finissait d'être installé, donc ça a coïncidé avec une baisse donc, du nombre de cas graves. Maintenant, concernant l'impact de ces mesures qui ont été prises, il faut noter qu'il est un peu difficile vraiment d'analyser cette situation, parce qu'en fait, au moment où on a mis en place ces algorithmes, au moment où on a impliqué les différents secteurs de la prise en charge, donc ça a coïncidé avec une diminution du nombre de cas au niveau de tout le pays, donc également une diminution du nombre de cas graves. Mais ce qu'il faut noter qu'au même moment, quand même, nous avons constaté une diminution du nombre de cas graves et une diminution du nombre de décès. Avant, on avait 7 décès par semaine, mais après la mise en place de ces mesures, nous sommes parvenus à avoir 2 décès par semaine. Mais comme je l'ai dit, c'est difficile de rattacher ça aux mesures, ça peut être juste dû à la diminution du nombre de cas. Et donc avec cette première vague, donc, ce que nous avons vraiment appris comme leçon, c'est surtout l'importance de mettre en place des protocoles, mais surtout les partager. Parce qu'on s'était rendu compte qu'il y avait des protocoles, mais au niveau périphérique, ces protocoles n'étaient pas partagés chez les prestataires. Mais également, l'importance d'impliquer plusieurs spécialistes. C'est vrai qu'au début, il y avait que les pneumologues et nous, infectiologues, qui nous chargions, et les réanimateurs, qui nous chargions de la prise en charge des patients. Mais on s'est rendu compte que du fait de la présence de comorbidités, on sait que ce sont ces comorbidités même qui sont responsables parfois des décès et qu'il fallait impliquer donc les autres secteurs. Mais également l'importance, la nécessité d'orienter de manière régulière, donc organiser des séances d'orientation, de formation pour la prise en charge. le renforcement des ressources humaines, parce qu'on a eu beaucoup de soucis également pour les ressources, notamment les réanimateurs, donc c'est une denrée rare, hein, donc dans nos pays, notamment au Sénégal, et surtout en périphérie, nous savons que la plupart des réanimateurs sont concentrés à Dakar, alors que dans les régions où on a des centres de traitement, vraiment c'était difficile d'avoir des réanimateurs. Mais également insister sur l'équipement de tous les centres de traitement et assurer une production qui est suffisante en oxygène, et essentiellement également, il faut relever le plateau technique au niveau de tous les centres de traitement. Alors maintenant, actuellement, nous assistons au niveau du Sénégal, nous assistons à une baisse, donc on a une tendance baissière du nombre de cas, donc effectivement nous avons aussi une tendance baissière par rapport au nombre de cas graves. Cependant, donc du fait que le virus circule toujours parce qu'on a beaucoup de cas communautaires, donc quand même pour éviter qu'il y ait une nouvelle flambée, notamment une troisième vague, il faut vraiment renforcer la surveillance à tous les niveaux, notamment au niveau pour assurer une détection rapide. Il faut assurer une bonne prise en charge donc des cas, surtout à domicile. En fait, ce sont ces cas à domicile. S'ils ne sont pas bien pris en charge, c'est eux qui vont disséminer la maladie au niveau de la communauté. Également, donc, il faut à ce niveau-là insister sur les mesures de PCI pour limiter la dissémination. Il faut également assurer un bon suivi des contacts, parce qu'actuellement, c'est ce qui a fait défaut lors de la G20, c'est surtout ça, donc il n'y avait pas un bon suivi des contacts, et également assurer une bonne couverture vaccinale, surtout pour les personnes à risque. Actuellement, au niveau du Sénégal, nous commençons à vacciner, et au total, nous avons 2,6% de la population sénégalaise donc, qui est vaccinée, et malheureusement, ça traîne un peu donc, pour la vaccination. Et je pense qu'il est important d'insister là-dessus et de sensibiliser la population par rapport à la maladie, mais également par rapport à l'importance de se vacciner et de respecter les mesures barrières, notamment le port de masque et la distanciation physique. Madame, ce sont les quelques éléments que je voulais, j'espère que je n'ai pas trop tiré en longueur, que je voulais partager avec vous pour ce qui est de la prise en charge des cas au niveau du Sénégal. Merci beaucoup.
Merci infiniment, professeur Daïta. Pour cette mise à jour de la prise en charge de la COVID-19 au Sénégal. I'm turning now to Dr. Norbert Njeka. Dr. Norbert Njeka, are you with us? Dr. Njeka?
Yes, I'm back online. I'm sorry.
Yes, Dr. Njeka, good morning again. Can you tell us about how South Africa is preparing for a possible resurgence in COVID-19 cases?
So thank you so much for the question. That's a very important question. I just want to say that we've had a total of 1,675,013 cases notified as of yesterday. This is cumulative, and yesterday alone we had 5,782 cases diagnosed. There have been over 1 million tests done so far in South Africa. What I can say in terms of the report, the response, the state president and the Minister of Health are two key figures in this, and you can see that there have been a lot of briefings by the president himself, and it's been very, very interesting to watch. But also there are technical committees, including the National Corona Command Council, the incident management team, where I serve in as a team lead for case management, and key interventions have been identified regarding the response to pandemic. You'll agree with me, governance and leadership is critical. Medical supplies, port and environmental health, epidemiological report and response, facility readiness. So this is some of the area, but more importantly, also risk communication and community engagement, infection control, occupational health, and issues around human resources. We have 3 provinces already that look like they are in the 3rd wave. The one is like they were still on the 2nd wave. They never really finished their 2nd wave. So one could also say that 4 provinces are experiencing significant increase in terms of cases. One is plateauing, but there's been like 20% comparing to previous weeks. Comparing the three epidemics, the three waves, it looks like what we noted using the 7-day moving average. So we compare the number of cases found like every 7 days, and we check whether there's increase or not. If there's 10% increase, that alert level 1. If we get 20%, level 2, and so on and so forth. So what we noticed is that with the first and the second and even the third wave, when we are around to 12 to 13 days past the mark of 2008 cases per day, then you take like 25 days to 26 days you take like 13 days to reach 5,000, and an additional 26 days will take you to a mark of 10,000 daily would pass that. Our first wave peak was like 12,000 a day. The second one was almost 20,000. And we're not sure. This one is starting more or less the same. 13 days ago, we passed our 2008 cases mark. Yesterday, we had more than 5,700 cases for one day alone. And this is mainly one province, Gauteng, that is doing this, that is giving more cases. Now, in terms of preparation, what we're doing really is to talk to our provinces, because we learned that despite early interventions, you get cases to increase at some point. These lessons learned from the first and the second wave, probably due to speculation. Some people say poor adherence to isolation, quarantine guidelines. At some point, people just get fatigued and they stop. They start to not adhere to non-pharmaceutical interventions, but also a lot of people have gone back to work during this period. So these are some of the factors that made it that perhaps we get the waves coming. And what we decided really learning from all this is that we need to increase community screening and contact tracing and have active and informed use of epidemiological data, community engagement, and the risk-adjusted strategy. But we're also looking at issues of strengthening health system. That's why we went to provinces precisely to prepare this, and we had workshop to identify key monitoring indicators to track a resurgence, because it's very important to know when is it happening before it even happens, so that you could start making plans. But also to establish thresholds and metrics that can alert a geographic area to a resurgence. That's why we're able to see that the one province started to climb first, and then second, and we're at the fourth one by now. So this is because of the metrics and the thresholds that have been put in place, and our provincial colleagues are, aware of this, and they are able to monitor. We're all able to see what's happening, but also we guide our provinces on actions to be taken to mitigate and respond to resurgence. So some of the things that we do is, for example, the hospital readiness. We look at human resource readiness in constant collaboration with our provincial colleagues, but also the hospital, management from our IMT, because we got several work streams depending on the key intervention areas, and this has helped a lot, because we're able, for example, to coordinate training for healthcare workers on an electronic platform, Knowledge Hub, which was there before COVID, but has never been really used. Now it's used like never before. But also we're monitoring hospital, functionality in terms of availability of beds, both for COVID and non-COVID. and ICU bed. We monitor all that. We monitor availability of ventilators, but more importantly, we also monitor the oxygen utilization at facilities, both private and public sector. We now have an electronic system to manage oxygen, which has been taken up by 50 hospitals in the country, which is very, very exciting. And we hope that this will grow to include other facilities. But I must point out that regarding oxygen, we do have hospitals with bulk supply and those who use cylinders. The one with bulk supply, our suppliers, Afrox, is able to see it centrally, electronically. And as soon as this drops to like 50% of utilization of the total stock, then they will replenish. But the one with cylinders is a bit difficult. We provided a calculator for usage depending on type of patients and the usage, so it changes from time to time, but it's up to the hospital to identify the need and order. So that's critical in terms of oxygen. In terms of availability of bed, it is communicated so that people will know in terms of referrals. They would know where to refer patients for COVID and so on and so forth, depending on the severity of the disease. We use mostly high flow nasal oxygen. A lot of patients require that, but sometimes they need intubation and ventilation and all that. So guidelines are being revisited. We have a committee that reviews the evidence in terms of what to use, what not. Can we use chloroquine or not? Can we use steroid or not? So all those things, we get information as a incident management team, and we relay information on the ground, and we monitor. Whenever there are problems, we call experts, we interview them electronically, and we're able to reach our colleagues. So this is in a nutshell how we preparing for the third wave. Like I said, a few provinces looks like in the middle of a third wave, but probably, I hope not, but it looks like experts have indicated it also that the rest of the other provinces will follow, and we might experience higher volumes, and we're getting ready for that. One of the elements that we also learned, and we've been preparing particularly, is the question of other services, essential services like TB services, HIV services, maternal, child and women's health, for example, family planning, immunization. We learned that with the second wave, some of those were nearly collapsed, and we're trying to maintain at least essential services with the third wave. Thank you so much for the question. Over,
Thank you so much, Dr. Norbert Njeka, for this comprehensive update of the situation in South Africa. Now we have heard from all our panelists, ladies and gentlemen from the press. It's your turn to ask questions. And to do this, please use the question and answer function on the Zoom platform. Remember also when asking your question to provide your name and the news organization you represent, so that you can have your question asked live or through me. We also have with us a certain number of experts. We have Dr. Richard Mihigo, Coordinator Immunization and Vaccine Development Program at the WHO Regional Office for Africa. We have with us Dr. Tierno Balde, Deputy Incident Manager, and Dr. John Apia Adabie, WHO Case Management Expert. All of them are here to answer your questions. Without too much further ado, we'll give the floor, first of all, to the members of the press who would like to go live. And we have Laurie from AP. Laurie, are you on the call?
I am. Can you hear me?
Yes.
Great. This is for anybody who is expert in the vaccine development and distribution. You had talked a little bit earlier today about the inequity of vaccine distribution and manufacture, and I'm wondering if there are any specific decisions that you think could have been made or should have been made differently to avoid this in the past year, moments that you thought were key, and also whether you think that what can be done in the short term given production constraints.
So this question is directed to Dr. Moeti.
Yes, or anybody. I understand you said there were others on the panel who are also involved in that in the vaccine distribution. So anybody who's really an expert in this.
Okay, let's start first to Dr. Moeti, and she will tell us if someone needs to add to her answer.
Okay. Thanks very much. Thank you, Laurie, for that question. I think, to be fair, we need to acknowledge this has been a quite unprecedented situation which has involved all countries in the world, literally, and decisions have been made as countries are adjusting, first and foremost, to their own situation, trying to plan ahead for this experience which has never been held before. And things have evolved, and this is where we are now. I think one of the best decisions that was made was to establish a multilateral platform for assuring or working towards equity of access to vaccines, from what we've learned from previous serious situations, including HIV, for example, access to antiretrovirals, which was a big challenge. But as we saw, as the situation evolved, individual countries, some of whom had invested in the development of vaccines, had to make decisions and balance the needs of their own populations and the needs of the world at large, because we've said many times that as long as some people are vulnerable, then the whole world remains vulnerable. Perhaps decisions might have been made to look at ensuring that the COVAX, this platform that was established, was supported, financed more actively. I believe that recognition of the limitations of manufacturing capacity for the whole world's needs might have come sooner. Not that it would have led to decisions to develop production capacity. This could have come sooner, I think, but also it could then have led to decisions about dose sharing early so that we could have countries more equitably moving along together in having access to some of the supplies. I think all that we can say is that it's good to be flexible and to adjust as we see the situation evolving. And we very much appreciate the decisions that are emerging now among the higher income countries, the announcement by President Biden, the announcement by the EU in terms of sharing larger quantities of doses. What is needed, for example, for the African situation, is really significantly more doses than are currently being released as donations to emerge sooner. I think this experience has been a very good one on which the world can learn and base for the next time in order for this faster action towards equity. I'll leave the discussion on manufacturing to Richard and say again there is very active, intense discussion, decision making and work going on at the level of African politicians, at the level of the African Union, and by Africa's partners, the European Union and others who are actively seeking to rapidly establish manufacturing capacity in African countries. And this is something that will be very important in the medium term and definitely in the long term in addressing this pandemic. So Richard, perhaps you'd like to supplement that.
Yeah, thank you, Dr. Moeti. I think clearly the one of the lessons that we've learned from this pandemic is how badly we were prepared in terms of vaccine security in the region and how clearly dependent the continent is from the vaccines that are currently coming from outside. Even with routine immunization, almost 99% of the vaccine production is happening outside the continent. As has been clearly said by Dr. Moeti, I think there is now a strong political commitment to try to address this issue as soon as possible. And it's not only for COVID-19 vaccines, but also for definitely in a more sustainable manner for vaccine security on the continent. And secondly, I think what the current discussion, how it's evolving, it's on how to put in place platform that could be very quickly turn out to produce vaccines for vaccine preventable threats that may emerge in the future. We hope that this will be the last pandemic, but I think it's better that we get prepared for any threat that may come in the future and how we can quickly respond to it. And then my last comment will be in terms of the short term, as you have asked, Laurie. I think we have heard a lot of goodwill and good commitment of high-income countries to share their dose. But for the moment, what really is lacking is to translate these commitments in a very concrete action in a short-term period. So we are seeing a lot of delays from the time when country made commitment for sharing those and when this is translated in actual delivery in the countries. So maybe this is where in the short term, we need absolutely to work as a global community to fulfill this promise of equity if that donation mechanism has to bear fruits in a short term. Thank you.
Thank you very much, Dr. Mihigo. We have a question from Claire Doyen, AFP, that I will ask in French, and actually it's for you, Dr. Mihigo. Après les difficultés d'approvisionnement que nous avons constatées, notamment avec le cas de l'Inde, Dr. Mihigo, we have a question from Claire Doyen, AFP, that I will ask in French, and actually it's for you, Dr. Mihigo. Après les difficultés d'approvisionnement que nous avons constatées, notamment avec le cas de l'Inde, une deuxième vague de livraison de COVAX est-elle en route en Afrique? Question de l'AFP.
Okay, merci, Madame Kouaovi. Effectivement, nous sommes tous malheureusement encore en train de vivre cette situation de crise sur le plan de la chaîne d'approvisionnement au niveau global. Il existe bien entendu au niveau du mécanisme COVAX des pistes qui sont en train d'être explorées pour essayer de pallier à ces ruptures dans le short term possible. La première action, c'est effectivement ce que nous venons de discuter tout à l'heure, accélérer le point sur la distribution des vaccins des pays qui en ont plus vers les pays les moins nantis, c'est-à-dire traduire en concrète action les dons ou les processus de donation qui ont été faits pour effectivement que ces vaccins arrivent dans les meilleurs délais au niveau des pays. Deuxièmement, au niveau de COVAX, effectivement, il y a également cette diversification du portefeuille des vaccins. On a vu que jusque-là, COVAX était certainement hyper dépendant de AstraZeneca, produit à travers les Serum Institute India. Et aujourd'hui, nous avons des accords qui ont été conclus, notamment avec Moderna, Johnson & Johnson, Novavax, bien entendu avec Pfizer, mais en petite quantité, pour effectivement élargir le portefeuille des vaccins. Mais malheureusement, ces nouveaux accords ne vont pas se traduire dans un court terme, c'est-à-dire dans les semaines à venir, avec une augmentation des livraisons. Donc, on compte effectivement à ce que les pays qui ont fait la proposition de partager leurs doses le fassent dans les meilleurs délais. Et c'est ça exactement qui va nous permettre de sortir dans cette situation de crise dans laquelle nous sommes. La semaine dernière, nous avons lancé un appel sur environ autour de 20 millions de doses qui sont nécessaires pour compléter les premières doses qui ont été jusque-là administrées. Donc, il faudra absolument que les choses aillent très rapidement pour que les pays qui ont déjà épuisé leur stock puissent effectivement administrer la deuxième dose dans les meilleurs délais. Merci.
Merci, Dr. Migo. Dr. Njeka, we have a question from Tobeka. Tobeka Ngema from the Daily News in South Africa. The question is this. A number of ARV recipients had complained that they were unable to get their ARVs from clinics during level 5 of the national lockdown, and this is because the medication was unavailable. What was the cause of this? If the country went back to level 5, how will the health department avoid this situation from happening again, Dr. Njeka?
Thank you so much for this very important question. What happened is that last year in March, when we went for our first lockdown, nobody really knew how long will it last, and there weren't proper plans in terms of how do we maintain TB services, HIV services, immunization, and so on and so forth. But much later, when we noticed that, for example, the case detection dropped 50% plus in some areas, we then asked provinces and districts to develop catch-up plans. So the plans are in place so that when we go into third wave, there should be a minimum package of care delivered. This is work in progress. We shall monitor implementation and address challenges.
Thank you very much, Dr. Njeka. I have a question directed to Dr. Moeti from Omar Mohamed from Reuters. Dr. Moeti, what do you say to Africans who are fatigued by restrictions but don't know when vaccines will reach them, while at the same time they are seeing a possible resurgence in their countries?
Yes, I think that's a brilliant question because it speaks to the heart of the dilemma, if you like, at the moment. We would like individuals, families, people in the communities to sustain the prevention measures. We have no choice. And I think what we can say to people is how much this is important for themselves, first of all, for their families, especially if there are people who have elderly people who have these illnesses that were so well described by our colleague that make them vulnerable to serious forms of the disease, to more or less keep going for the collective good, for the good of themselves, for their families, because in the end, this is what is going to get us the freedom to be able to normalize life. It's very difficult, I know. And I think what we can see is what we can say is that indeed we have been disappointed because the rollout of vaccines has not been as we had hoped and had originally been planned. But it is coming. I also will say that our expectation is that these acute difficulties that my colleague Richard was talking about now are going to ease. We're expecting that in the third quarter, so starting from around July, August, we are expecting to start to see volumes of vaccine increasing. It was said that WHO has just issued the emergency use licensing of another Chinese vaccine. We're expecting then this vaccine to be more available. So I can only say to people, it's going to get better. It's been very difficult in the last couple of months. We've been very disappointed that the vaccine campaigns haven't been able to roll out as we had expected. But I would like to encourage people, please keep going. Do your best. Make sure that you have your mask. I also would like to request governments, partners, to provide support to people who can't actually afford to buy a mask or even to have a mask made, to have the mask distributed free, because that will help people as well. But just do your best. Even if we see in Southern Africa, for example, that the winter is starting, people will have to stay indoors. Keep away from crowded areas, particularly indoor crowding, and minimize some of the things that you might normally do in your normal life. And let's have the patience. We sympathize very much. It's been a long road. It's been over a year. But I'm very optimistic it'll soon be over, because I expect in a few months the vaccine availability situation is going to change. And now we will have the job of making sure that we get those vaccines into the arms of people who are waiting patiently. Thank you.
Thank you very much, Dr. Moeti, for these words of optimism. I will turn now to Esther Nakazi, a journalist in Uganda. She is willing to go live. Esther, are you on the call?
Yes, I am. Can you hear me?
Yes.
Thank you very much. My question goes to Dr. Moeti and probably Dr. Muhigo. We know, or I understand that in terms of dose sharing, donor countries are earmarking which geographical region the doses that they want to share go to. And in your opinion, are there any parameters that are existing to ensure equity and donors playing favorites when they say, I want my doses to go probably to East African region or West African region? What are you doing about it? Thank you.
Okay, I think we've seen a combination of indications by the countries donating vaccines. Some have started with donating to specific countries, but for example, the announcement made by the US president recently of the 80 million doses indicated that a significant proportion of those would be through COVAX. And we are more and more hearing the partners indicate that they would like to donate through this mechanism, which is one way of ensuring equity, because it's a very basic principle of COVAX. We know, of course, we expect that some of the doses might also be provided through the African Union, and I know that their mechanism, the AVAT, also is very much emphasizing equity. So I think we have a combined picture. We can only encourage those who are donating to do so in a way that enables, as I said before, us all to move along together in the whole world. So, as we are increasing the proportion of people covered in one country, we're hoping to do that across the continent, since we're having to catch up with the rest of the world. And we would very much like to encourage the donations to happen in that way.
Thank you, Dr. Moeti. Nous avons une question de Jeanne Richard de RFI qui s'adresse au professeur Daïka. Professeur, est-ce que le Sénégal utilise toujours l'hydroxychloroquine pour le traitement de la COVID-19, sachant qu'aujourd'hui, plusieurs études scientifiques ont conclu à l'inefficacité de cette molécule et sachant aussi que l'OMS ne recommande pas ce traitement?
Allô?
Oui.
J'ai pas très bien entendu le début de la question.
Oui, c'est une question de RFI de Jeanne Richard qui demande est-ce que le Sénégal continue d'utiliser l'hydroxychloroquine comme traitement de la COVID-19, sachant d'une part que plusieurs études ont conclu à l'inefficacité de cette molécule et d'autre part que l'OMS ne recommande pas ce traitement?
Merci beaucoup, madame, pour cette question fort importante. Effectivement, nous, dès le début de la pandémie, donc nous avons commencé à utiliser l'hydroxychloroquine. Et d'ailleurs, même, il y a un essai clinique donc, qui a été fait au niveau de nos centres de traitement, notamment au niveau de Dakar. Donc, cet essai qui concernait l'hydroxychloroquine et l'azithromycine, donc ce n'est pas uniquement l'hydroxychloroquine. Et donc, effectivement, cet essai, quand même, nous avions des résultats préliminaires. Et d'ailleurs, même l'article a été soumis dans des revues de publication, donc qui avait juste montré quand même pour les formes modérées que ça pouvait diminuer la durée d'hospitalisation. Mais actuellement, au niveau des CT, il faut noter que pour les formes graves, c'est-à-dire que regroupe les formes sévères et les formes critiques, on n'utilise pas l'hydroxychloroquine. Également, pour ce qui est de la prise en charge à domicile, c'est-à-dire les patients qui sont suivis dans les maisons, qui ne peuvent pas bénéficier d'électrocardiogramme, donc ces patients ne doivent pas donc bénéficier d'utiliser l'hydroxychloroquine. Donc c'est surtout chez les patients modérés et donc qui bénéficient d'abord d'un électrocardiogramme. S'il n'y a pas de contre-indication, on les met sur azithro associé à l'hydroxychloroquine. chloroquine. Mais pour les formes graves et les formes sévères, la prise en charge repose essentiellement donc, sur la corticothérapie, donc, qui est recommandée par l'Organisation mondiale de la santé, notamment la dexaméthasone, mais également l'oxygénothérapie et le traitement anticoagulant selon les cas. Merci.
D'accord, merci infiniment, professeur. Next question is to Dr. Moeti. Dr. Moeti, this past weekend, South African President Cyril Ramaphosa indicated the positivity rate for COVID-19 tests in South Africa is around 11%. Can WHO respond to how concerning that particular figure is and how it compares to other African countries and maybe other countries across the world? Is it possible to put that figure in context for us in terms of how worrying it is and how it compares globally? To how concerning that particular figure is and how it compares to other African countries and maybe other countries across the world. Is it possible to put that figure in context for us in terms of how worrying it is and how it compares globally?
Okay, thank you very much for that that question. I think WHO indicates that if a positivity rate is over 10%, that is a concern. It shows then that the identification of cases is indicating a high level of positivity in the population. So, of course, in the case of South Africa, in a country where the cases are going up, and in a country where the testing is reasonably adequate, having a over 10% positivity rate is a cause for concern. It means that that really is then a situation where the positivity is significant. How does it compare with other countries? We've seen that overall, cumulatively in Africa, the positivity rate is around 10.4%. With about 33 countries, we've seen test under 10% in the past 28 days. So, for example, countries like Zimbabwe is at 2%, Nigeria 1.1%, although there the rate of testing might not be as high as it is in South Africa. Namibia, which is testing significantly, is at 18.2%. So that's really a cause for concern. A country like Argentina is at 33%. We've seen that some of the Latin American countries have been very severely affected and with variants that are highly transmissible. The US is at about 3.3%. So this gives a range of situations that you can compare. Certainly 11% is cause for concern, particularly in a country which is doing a reasonable and quite high level of testing.
Okay, thank you very much, Dr. Moeti. I forgot to say that question was from AP, from Gerald Inouye. Now, we have a question from Nathalie Mora Chinois to Richard. Richard, Dr. Migo, please, can you highlight for us the process of the rollout of the COVID-19 vaccines in Africa? That's one question. And the follow-up question is, do you foresee the continent attaining the 10% vaccination target against COVID-19 by September? Dr. Migo.
Yeah, thank you. Thank you, Madam Kourouvi. Well, I think we have seen a situation where we've come from a long way in the African region. Most of the countries started to roll out their vaccine around end of February, beginning of March, which coincided with the first delivery of vaccines that are coming through the COVAX facility. As of today, we have already 50 countries in Africa, and the last country being Burkina Faso that have received the country. And as of yesterday, Chad received also its country, bringing the number of countries to 51, by the way, in Africa that have now having vaccine. So quite a very good progress the last 3 months in terms of number of countries that are rolling out the vaccines. We have only now 3 countries that are remaining, which have not yet received the vaccines: Eritrea, Burundi, and Tanzania. Of those 51 countries that have received the vaccines, we have around 48 million doses that have been distributed across Africa, and 31 million doses that have been already used, which brings us around 65% of the doses that have been administered on the continent. So quite a very good progress from where we came from. And we've heard from the brief opening remark from Dr. Moeti, a certain number of countries that have even used up most of their doses. We do have, however, few challenges in few countries in terms of implementation of the vaccine for many reasons that we are trying to address. And the focus now has been on how collectively we can support countries to move to the next step, completing the second dose, and as you have heard, preparing for the delivery of more substantial doses starting the third quarter of this year. So coming from a long way, very good progress, few issues the last couple of weeks in terms of availability of the supply, but very good prospects moving forward in terms of increasing volumes of vaccines. And I think we are trying to also to take this opportunity to work with countries to prepare better for the rollout of these vaccines moving forward. Now, with the 10% target by the end of September, I think certainly this is a very, very important milestone that was raised by the WHO Director General during the World Health Assembly. We have already estimated how many doses are needed to help every country to reach that target. It is a very ambitious target, we know, but it's a very necessary target. We're working, really supporting countries hard to get to that point. It will be very challenging, but if those increase, if the supply increase, and the support to the country, we could potentially, with the support of WHO and partners, help countries to get closer to that objective. Over.
Thank you very much, Dr. Minigo, for this comprehensive answer. I'm turning to Dr. Njeka. Dr. Njeka, in Western countries, people who are vaccinated will be very soon able to start traveling, and we know that people who are vaccinated can still be infected and they can still transmit the COVID to another person. So should African countries be worried about it?
I'm not sure whether we should be worried about people who are vaccinated traveling. The issue is that many people have to travel for work, and the various lockdowns that we've had have really killed some of the businesses. A lot of entrepreneurs have closed and all that. So people have got to travel if they've had vaccination. What we do in South Africa, really, we've been advising people to continue to observe social distancing, wearing masks, because very few people have been vaccinated. Most people are not yet vaccinated, so you can't tell anyone stop using a mask and all that. And indeed, we've seen a few people who got the disease after being vaccinated, but also people are anxious about the vaccines. There are people who would say, I'm okay, give me the vaccine. Meanwhile, they were having other health issues. So all these are problems that we have, and we've got to deal with them. But I think traveling should be for essential reasons. I'm not sure whether we've reached a point where we should be traveling for parties, for leisure. Maybe not yet, probably for business, it is justified. Thank you.
Thank you. Thank you very much. The next question comes from BBC, Rhoda Odhiambo, and it is directed to either Dr. Minigo or Dr. Moeti. The question is this, just seeking clarification on what it means for a person to be fully vaccinated. In Europe, one is only regarded fully vaccinated 14 days after the second jab. Is there a general or global rule? And if yes, what is the significance of the 14-day window?
Okay, thank you. As you've said, several of the vaccines that are being used need a second dose in order for the immune response that is triggered by the vaccination to reach a level that is optimal in terms of what the vaccine must do. And several of them actually don't prevent infection, but they prevent severe disease. So I think it's a matter of really giving time for the vaccine to trigger the immune response, the production of antibodies in the person that is vaccinated, so that they can be able then to have the vaccine can be able to have the impact in terms of reducing risk of either acquiring the virus if the person is exposed, or getting seriously ill if the person is exposed. It is simply that I can't be vaccinated today and assume the vaccine tomorrow is having the impact that I'm expecting. This immunological response, this biological response in my body, producing several elements of the efficacy in terms of resistance of infection or ability to modify and moderate the severity of my disease takes some time. That's why this kind of period is defined. So it's 2 weeks apparently. I think this is the level of time it takes for the biological response to happen. So you reach a level of where the efficacy of the vaccine will be able to start.
Thank you very much. We are running out of time. I would like now to wrap up this press conference, and we can turn to our panelists and hear the final messages. You have about 1 minute each. If in the meantime there is a final question, I would like you to answer that final question while wrapping up. I would like for Dr. Moeti, for example, in your wrap up, if you can reply to that question. What about the COVID-19 virus variants that are currently circulating in Africa? What about the efficacy of the vaccines that are currently available in Africa against these variants that are circulating? And if you could, Dr. Moeti, answer this question while wrapping up. Thank you very much.
Okay. Yes, there are several variants circulating in African countries, as they are all over the world. So these variants have just recently been renamed by WHO. So we've had for some months in a combination of countries, the Alpha, the ex-UK variant, the Beta, which is what we used to be calling the South African variant, and the Delta, the variant that's circulating in India, that are circulating. The latter has just started more recently circulating in African countries. And the efficacy of the vaccine is varied. Certainly there was data from a small survey indicating from the AstraZeneca vaccine's efficacy against the Beta variant was reduced, but particularly in terms of severe, mild illness, although it was thought it probably would be effective against severe illness. Our impression overall is that more data is still being gathered, but the vaccine efficacy against the variants is adequate for them to be used. So we would like African countries to continue to use the vaccines that are available. Certainly the AstraZeneca vaccine, there is some hesitancy in some of the countries that have a high level of circulation of the Beta variant. And luckily, there are other vaccines that are coming on board that will be available. I think the most important thing is to continue to collect the data and continue to study this efficacy of different vaccines, and fortunately, to be able to have the choice for countries to use the vaccine that is optimally efficacious based on the variants that are circulating in that country. And then if this is my chance to say a concluding statement, I would like to, first of all, thank the journalists who've joined us. Thank very much our two panelists for sharing perspectives, particularly from the case management point of view. This is, I was very struck by the comments from our colleague from Senegal, all the learning that has happened, really driving the idea of it's important to have an integrated approach among specialists and to think about where people need to get treatment that is close to them. It will not be in an ICU, in a specialized hospital in the capital city. So this underlines, again, the importance of what we are promoting very much in WHO, universal health coverage, having at the different levels of the health system what's appropriate and feasible to do so that people can get the best treatment that they can close to where they live. And just to conclude, I'd like to repeat again and my encouragement to people in our communities. The vaccine issue will be solved. And I'm very optimistic about what's going to happen in the next few months. We've gone through a very difficult, and are currently today going through a difficult period in terms of having adequate vaccines for the second dose in most of our countries. But I'm very optimistic that in the next few months, we will start to see an increase in the availability, the diversity of vaccines that are licensed. Please, let's keep up what we can do in our own individual families, at our workplaces, wearing our mask correctly, keeping a distance to the extent possible, not going to indoor gatherings to the extent possible, and washing our hands frequently so we're not moving the virus that way. Thank you very much for having joined us today.
Thank you, Dr. Moeti. You heard Dr. Moeti. Keep your distances, keep social distancing, the precautions, and we will soon get all vaccinated. Let me give the floor, Professeur K. Je vous donne la parole pour quelques mots de conclusion.
Merci beaucoup. En tout cas, c'est un plaisir d'écouter tous ces panélistes donc pour vraiment ces informations très importantes qu'ils ont eu à livrer ce matin. Alors moi, juste pour conclure, je voulais vraiment insister. Bon, actuellement, je sais qu'en tout cas au niveau du Sénégal, nous assistons à une tendance baissière de l'épidémie. Je pense que c'est le cas pour plusieurs pays. Mais il faut vraiment qu'on fasse attention parce que vu que le virus circule toujours, parce que nous avons toujours des cas communautaires, et malheureusement, en tout cas au niveau du Sénégal, toutes les activités ont presque repris. Donc, il y a plus de distanciation physique, le port de masque également est négligé. Et également, malheureusement, il y a pas une adhésion des populations par rapport à la vaccination. Parce qu'il y a beaucoup de réticences, et surtout depuis avec les cas qui sont avec AstraZeneca, les populations sont réticentes par rapport à la vaccination, ce qui fait que nous n'avons pas une bonne couverture vaccinale. Et malheureusement, les activités ont repris, donc je pense que vraiment, il faut qu'on sensibilise les populations. Donc, il faut aller au niveau des communautés, les sensibiliser, mais surtout les impliquer dans la prévention pour éviter une éventuelle seconde vague. L'autre élément également, c'est par rapport aux autorités, mais également par rapport aux structures de santé. Je pense que c'est en ce moment où il y a vraiment cette tendance qu'il faut se préparer pour une éventuelle première vague, parce que nous avons beaucoup, troisième vague, parce que nous avons beaucoup appris de la deuxième vague avec le problème de lits de réanimation, avec le défaut de production d'oxygène, avec le problème de ressources humaines. Je pense en ce moment qu'il faut se préparer, mettre en place tout ce dispositif pour pouvoir faire face à une troisième vague. En tout cas, ce sont les mots de la fin que j'avais et je vous remercie encore de m'avoir associé à cet important panel. Merci beaucoup.
Merci, professeur K, pour ces mots de sagesse. Mieux vaut prévenir que guérir, toujours. Let me give the floor to Dr. Njeka for his concluding remarks.
Thank you so much, Madam Facilitator. What I would say really as a concluding remark is that it is clear from expert reports that all countries are not diagnosing, are not finding all the cases that exist. So what we have reported now is not necessarily what we have. We do have far more than what we are notifying. So we need to intensify case finding. We need to make it integrated with TB, with HIV, so that we can find more cases. We can resuscitate TB services, HIV services that are collapsing because they've been too much focus on COVID, and they tend to collapse. Secondly, the COVID is a challenge, but it's exposing old challenges of our weak health systems. So we need to really look at that, reflect on that seriously. There are also opportunities. For example, now we do have better collaboration in South Africa and in many countries between private and public sector. It wasn't there before. We need to capitalize on that. We managed to convince most of our people to be wearing masks. This is a good habit. It's required. We needed it yesterday for household of TB and other conditions. So these are things that need to really be intensified, and we must take the vaccine. Unfortunately, I have to say this. Must address misconceptions and, get our continent, our region vaccinated so that we could deal with this pandemic in other ways. Probably vaccine is a very important part of the fight against COVID. Thank you.
Thank you very much, Dr. Njeka. This is the end of our virtual press conference. I would like to thank.
This show has been produced by Depictions Media. Please contact us at depictions.media for more information.